What are the current diagnostic protocols for identifying and managing oral potentially malignant disorders?
So this is a two-part question. For identifying an oral potentially malignant disorder or lesion, this really is clinical diagnostics, evaluating a patient, evaluating a lesion, and figuring out whether we're going to consider in our differential diagnosis whether this is something that could be preneoplastic or in that spectrum or category of an oral potential malignant disorder or lesion. Typically, once this has been identified, we biopsy these patients or these lesions specifically, and then that biopsy is sent to a pathologist. And you can get one of a few diagnoses, whether it's dysplastic or non-dysplastic. And then now comes the problem, is how do we manage these patients, right? There's no standard or universal protocol in regards to management of preneoplastic lesions or oral potentially malignant disorders. And inherently, we're in a state currently that we're using histologic evaluation, which we are all aware is subjective in regards to coming up with a diagnosis and making our prognostic protocols on how we're going to follow up with these patients. Typically, with dysplasia, we can have either a two-tier system of low-grade epithelial dysplasia or high-grade epithelial dysplasia, or a three-tier system where it's mild, moderate, and severe epithelial dysplasia. Longitudinal data tells us that, hey, mild dysplasia has a lower risk or lower chance of progression to squamous cell carcinoma. That being said, we're in an era where molecular changes and genetic alterations are what really drive transformation. And histologic grade doesn't necessarily correlate to transformation. So when you come up to a diagnosis of mild dysplasia, you could have 10 individuals that can have really differing opinions on how to manage cases of mild dysplasia or moderate dysplasia. The higher grade dysplasia we typically get, the more agreement there is that there needs to be something proactive in regards to management for that patient. But with low grade dysplasias or non-dysplastic preneoplastic lesions, whether it be leukoplakias or others, there really is no universal agreement or protocol for management. So it really is up to the clinician, and there have been various recommendations made by different academies and institutes, a white paper from Amos, as well as a statement from the American Academy of Rural Medicine. And these are loose protocols, and I think, if we look at the trends, there is a more proactive approach that's being kind of seeped into the literature in regards to management of disease.
What is Stratocyte and how does it assist with oral potentially malignant disorders assessment?
Stratocyte testing is the next era in predictive evaluation in regards to precancerous lesions progressing or transforming into squamous cell carcinoma. We're actually using our understanding, which we've accumulated over decades, of biomarkers, as well as the current generation and data of AI and machine learning to evaluate each lesion and specifically give you a tailored index or prognostic curve of the rate of transformation of that lesion to malignancy over a 5-year period.
How does Stratocyte compare to the current standard of care for evaluating oral potentially malignant disorders? Does it offer a clinical advantage?
The current standard of assessment for oral potentially malignant disorders is based off of histologic evaluation, which is a pathologist looking at tissue under a microscope and giving you a diagnosis of dysplasia or non-dysplastic changes. When compared to the current standard of care, Proteocyte is utilizing a specific biomarker that has been shown to be increased and overexpressed in cases that will progress to squamous cell carcinoma, as well as machine learning looking at cytomorphometric parameters to give us a more objective idea of the rates of transformation of lesions outside of what we can just see.
What are the potential benefits of integrating Stratocyte into practice for both patient outcomes and clinical workflow?
The benefits of integrating Stratocyte into a clinical workflow are numerous. Whereas you are left with a diagnosis of mild epithelial dysplasia and wondering what the chances of a lesion to progress to squamous cell carcinoma are, now we're giving you specific numbers of that lesion and whether it's at an elevated risk or a lower risk of transforming to squamous cell carcinoma. This can drastically change how you follow up with patients, a shorter recall for certain patients, a longer recall period for certain patients, and whether or not we need to be proactive in regards to treatment, whether it's through resection, laser ablation, topical chemotherapeutics, or we're going to monitor a patient. This changes the entire environment and understanding of how we're going to manage patients going forward for oral potentially malignant disorders.
Why should oral healthcare providers involved in the detection and treatment of oral cancer take interest in this innovation?
Why should we take an interest in Stratocyte? To answer that question, you're going to understand that we've been utilizing the same histologic evaluation for decades with somewhat subjective interpretation of what a pathologist can see under a microscope, as well as iterations of the same treatment and management protocols for taking care of our patients with oral potentially malignant disorders. Stratocyte is utilizing what we have learned in regards to molecular pathways and the utilization of biomarkers, as well as AI and machine learning, to give us a leg up and join the era that we're in for objective information that we can readily utilize in regards to transformation rates of precancerous lesions in developing into a squamous cell carcinoma.
What are the cost considerations and reimbursement pathways associated with adopting Stratocyte?
Stratocyte testing can be a little bit daunting, especially if you're going to incorporate something new into a practice and you're thinking just like me, well, this is a new pathway, there may be new costs associated with it. Proteocyte is actually a patient-centric company. Proteocyte is in contract or in communication with private insurance companies across the US, getting reimbursements from certain companies like United Healthcare, and currently in talks with Medicare as well as other providers in the United States.
How do I order Stratocyte?
Stratocyte is extremely easy to order. It's as simple as going to the website and downloading the test request form and sending it in. Proteocyte and Stratocyte will take care of the rest by getting in touch with the lab, getting the tissue ordered, and performing the test and study, and then you'll receive a report.
What is included in a Stratocyte report?
When you receive a Stratocyte report, the biggest thing you're going to see is whether the patient is at an elevated risk or a low risk in regards to transformation of that biopsied lesion to squamous cell carcinoma. Additionally, you'll get a personalized breakdown of that lesion in regards to transformation over a 5-year period.
Please share your Stratocyte experience.
Personally, I have received feedback from patients that have ordered Stratocyte testing or sought out Stratocyte testing, as well as clinicians that are taking care of patients that have ordered the testing. The big thing here is it's providing more objective information and education to clinicians and patients both on what they should be doing for a specific oral potentially malignant lesion.
Why Stratocyte?
As everybody's aware, oral cancer is on the rise and has been on the rise. I often tell people oral cancer is not like other cancers, and not to minimize other cancers, but as humans, we communicate through our speech, we get our nutrition through our mouths, and people recognize us by our face. So when a patient is afflicted with oral or head and neck cancer, it is inevitable that they lose a portion of their identity. Stratocyte is the next era of testing that is going to provide more objective information on how we should manage patients with oral potentially malignant lesions and disorders.